Oh, shoot. I can't get it to be. Won't say anything. Hello, everybody. Thank you for joining us. I see that Dr. Pearson has logged on.
I'm here.
I'm so glad to have you. I'm still admitting people. We had about 80 people RSVP, so seems like
Okay,
an important topic that everybody's interested in hearing about. Certainly,
I'm sure.
certainly pertains to our community. So I'm going to give everybody just a couple more minutes to get logged on, and then I'm going to go ahead and let you share your screen in just a couple minutes.
Okay, that's perfect.
So, Dr. Pearson, I think I just made you co-host. See if you can go ahead and share your screen. That way I can continue to admit people and you won't have to be worried about that.
And see, which one do I want to do? Maybe I'll share over. Share this one. Okay, can you see it?
No.
Oh dear. Let me do. Oh no, here I didn't push this.
There you go.
There. Okay.
There you go.
Now we need this and we need this. Okay.
There we go. Now we're cooking.
Now
Well,
we are.
yeah, I just want to welcome everybody joining us today. My name is Kim Smiley. I'm the executive director of the Down Syndrome Partnership. We appreciate everybody joining us for our monthly speak session. This will be recorded and put up on our YouTube channel after this is completed. And I just wanted to take a minute to introduce Dr. Hillary Pearson. She is speaking with us today about sleep disturbances in kids with Down syndrome. Dr. Pearson is the medical director at the sleep lab at Cook Children's Medical Center. And if you guys can make sure throughout the program that we're remaining, you keep your microphone muted. And if you have questions, go ahead and put them in the chat. And I will stop throughout the process or Dr. Pearson will stop us throughout the process and see if anybody has any questions, and we'll go through those questions in the chat. So having said all of that, I'd like to turn it over to Dr. Pearson.
Okay. Yes. Welcome, everybody. Thanks for coming. I have like 25 slides. So I feel like that should give us plenty of time to then have questions at the end too. If I race over something that you wanted to ask or think of something in the end, I'm happy to either interrupt or do them at the end, or probably both, I imagine. Um, I have been at Cook Children since 2011, and certainly learning about the sleep disturbances that are specific to kids with Down syndrome. It still is something that I'm learning about. I even think, I didn't quite put this in the talk, but something that I've always been struck with is that I've taken care of a couple kids with Down syndrome that seem to have more of a PTSD kind of response to upsetting events than other kids. And one thing that I can think of three specific cases where we've had to work through returning to a good night of sleep because of the anxiety and the worried behaviors and thoughts that were intruding into these kids' lives. And it was more than what other kids, I think, would have felt and emoted. And I just think there's something for me to learn at every turn. So here we go. If we can go. Okay, there we are. So I always want to start with just a description about sleep for everybody. And even my little side note you see there at the bottom, because as parents, I think sometimes we don't do a good enough job of protecting our own sleep. And so I want to make sure that we are all remembering that healthy sleep in adults is important for our own health. Decreased sleep, so just simply not getting enough sleep hours at night, regardless of what your sleep disorders are, just the right number of hours at night. If you get less, it is associated with the development of diabetes, heart disease, high blood pressure, more strokes, more heart attacks, depression symptoms, and weight gain. So it seems that what we're learning, certainly through the adult world, is that if you don't sleep enough, you are in a pro-inflammatory state. And inflammation in your body is what is probably the cause of diabetes. And then diabetes is what leads to all these negative cardiovascular findings. The other thing about having a pro-inflammatory state is it's what ages you. So people that look older than their age, it's because they've had more inflammatory conditions. Even allergies are considered an inflammatory state. So we have to protect our own sleep too. We also need to be thinking about our children because poor sleep is associated with anxiety, emotional problems, and depression symptoms in younger kids too. And there were some specific studies that were sort of interesting that looked at less sleep and how kids performed the next day in school. And specifically, they will have trouble with addition, word memory tasks, verbal creativity, learning abstract concepts. And the teachers, of course, will say that those kids are the ones that have more trouble with attention. There were some specific studies done in children with Down syndrome, and I think I have a slide in here of that, showing that kids that sleep better seem to have more language acquisition overall, looking at Ages 6 to 14, the period of acquiring language is a little earlier, but the kids who sleep well during that time in their lives seem to have more words available to them for use, which is sort of wild and interesting. So what do I mean by get enough sleep? This is the recommendation from the National Sleep Foundation. They are a little bit more loosey-goosey with their hours than I am. When I am talking to families in the clinic room, I tend to pick one set of hours and stick with that. So for me, if you are in this school age range where your kid is 6 to 12, like, first to seventh grade, I think you should be getting 10 hours of sleep a night. And I think they tend to think that there are kids and there's some variability in these groups. I'm pretty specific about we aim for 10 hours. And that way, if your kid gets 9.5, or if they get 10.5 and that's what they need, then that's great. I talk to school age kids about 10 hours. I talk to teenagers about 9.5 hours, or 9 hours and 20 minutes to be specific. I will frequently give up on the 20 minutes. If I can get 9 hours out of my teenagers, I'm thrilled. But I think they all agree, begrudgingly or not, that they feel better when they get 9 hours of sleep. I think 8 and less than 8 is not enough for a teenage brain. And so then we get to 18 and up, and that's, then we're all grouped into this big adult grouping. I personally know that I do better on 8.5 hours of sleep. I think 7 is too little for adults. I think 8 is probably the line. But, I guess that can always be debated. There is such a thing as short sleepers.
Mm-hmm.
It's a very small percentage of humans in the world, and they're probably down at 5 to 6 hours a night. But I think a lot of people claim to be short sleepers, and I'm not sure I believe them. So there we have it. We are in a bit of a crisis in terms of insufficient sleep in the United States. I like this slide because in general, you can look at the United States and say, okay, so somewhere between 25 and 50% of us are not, the children are not getting the sleep that they need based on the previous slide there. The interesting thing to me is that it's grouped. So, you look at this group of 37 to 50% of kids not getting enough sleep. And it's kind of the South and Southeast. I think so. I don't know if that means that it's cultural for us not to get enough sleep or what that means. I mean, in general, what I take away from this is that there's a large percentage of kids that are not getting as much sleep as they should overnight. And this is even down to babies, 4 months to 14 years. Doesn't even include the teenagers. So, talking today specifically about sleep disturbances and what can get in the way of our sleep, I try to group them into 3 sort of buckets. So we have our breathing problems, our movement problems, and then what I call cerebral, or sort of what your brain does to help you not sleep or to make sleep harder. That's how I'll be breaking it down today. So I, of course, had to do something sort of silly, but where I'm highlighting some of the businesses that I love that go along with kids with Down syndrome. So some of these are owned by the kids or young adults with Down syndrome, and some of them are just places that folks are working. But so we all know in Fort Worth, we all know about Austin and his Underdog hot dog mobile transportation system. And so my joke here is that if you eat too many of Austin's Underdogs, which are fabulous, then you might have hiccups, and then you might have a breathing abnormality. Of course, not at bedtime, so it doesn't really work the whole way. But we'll start with breathing abnormalities because this is the most common sleep disorder type in children, and certainly in kids with Down syndrome. So obstructive sleep apnea across the board is, other than behavioral problems of not getting to sleep on time, obstructive sleep apnea is the biggest problem that we see, especially in the sleep clinic. So somewhere in the 1 to 4%, some studies are as high as 5 to 8% of children overall have obstructive sleep apnea, but it is quite high in patients with Down syndrome at 66%, much higher. And there are lots of reasons for that. Certainly muscle tone can be part of the problem. Kids with Down syndrome have smaller mid faces, so there is just simply less room for everything in there. So then if you combine an allergy or an allergic problem with enlarged adenoids and a tiny palate, then there's just simply not enough room in your airway for air exchange to happen in a smooth manner. We classify this in pediatrics. So this is sort of my general discussion. There is not a great consensus on this. So if you moved to our state from somewhere else, um, other states may and other centers may use different numbers than this, but I think we're getting closer to agreeing that 2 to 5 breathing problems per hour, so 2 to 5 obstructive events, would be considered mild sleep apnea. 6 to 9 is moderate, and 10 and above would be considered severe. Here's just a general list of all the treatments that are possible for obstructive sleep apnea, and we're always trying new ones and trying to figure out if there are other pathways that we should be attacking with this. And part of the reason is because, as we just mentioned, even just with kids in Down syndrome, there are different, I keep beeping, there are different places that this could be attacked, that we could try to make it better for or easier for kids to breathe. So what are we talking about? This is an example of what I see on a sleep study. So this is 1 minute of sleep stretching across this square here. We look at sleep in 30-second divots overnight, and then sometimes we crunch it up to look sort of at a bigger picture. What you're seeing up here, I can tell that this patient is in his or her dreaming sleep, REM sleep, because of these eye movements. So this is a sticker that's on each side of the eye. Here's left, here's right. And when your eyes flicker like this, you're either awake or you're in your dreaming sleep. And I know that this kid's asleep because of his brain waves that are right here. So this is the EEG leads that are placed on patients when they have sleep studies. And then here, these green lines are the leg movements. These top two flow monitors are at the nose. And then this is a stretchy belt around the patient's chest. And this is a stretchy belt around the patient's abdomen. And here's our oxygenation numbers. You can't quite see those, it's very blurry. But the obvious part I wanted to show was that this is very flat. There is no air coming in at the nasal level, but your body is still trying to breathe. Your chest is still moving up and down, trying to take breaths. So this is an obstructive apnea. And that's what we see in the 2 to 5 times an hour range to give you the diagnosis of mild sleep apnea. So now I'm backing out. So this is, let's see, 1 minute. This is 2 minutes of sleep. And if we back out and look at what sleep apnea can look like, you can see it's apnea after apnea after apnea. Here's a hypopnea, hypopnea. Hypopnea is simply an apnea is a flat nasal monitor, like I showed in the last picture. Hypopnea is where you're trying to breathe, but you're still not getting enough air in. And so you have an oxygen desaturation that's noted here with this green color. And also you have an arousal from sleep. And those are the two negative things about sleep apnea. It causes you to have oxygen changes, and there are certain cells in your body that require normal oxygenation, particularly in your brain. And then there's a center in your heart that needs you to have normal oxygenation numbers. So that's why sleep apnea is bad for your cardiovascular system. Your cardiovascular, certain cells in your heart cannot take this off and on, off and on, off and on normal oxygenation environment that happens in severe obstructive sleep apnea. So this is what it looks like. And you're waking up. These aren't full, sit up kind of awakenings, but it's just enough to disturb your sleep to make it not continuous, not sustained. And therefore, we see trouble with ability to learn the following day. We see trouble with falling asleep during the day. This is what sleep apnea looks like. Now, what can we do to fix obstructive sleep apnea? Well, here's one thing that we can do to help with obstructive sleep apnea. Obviously, these are somebody's tonsils that are absolutely enormous. They're cute little kid uvula is like laying down on top of this tonsil here. You can even see that this kid has a tonsil stone, which is strange and exciting. So obviously hard to get air in when this is what's blocking your airway here. So this all is of fairly normal size for maybe a 5 or 6 year old. Their palate is not too severely narrowed, but obviously it would be hard to get air past that. And you can even see like these extend way far back into his airway. So obviously removal of tonsils and adenoids is our first line therapy for sleep apnea. Now we have some other different kind of treatments. This is one that's sort of new, and I think in the next 5 years, I'm hoping gets a lot more press and maybe thought about it. These are maxillary expanders. And so you might hear your orthodontist or your dentist talk about palatal expansion because the original device was made to widen the palate. And then it was sort of secondarily noticed that this also improved obstructive sleep apnea. So here are a couple different models of palatal expanders, and the either the orthodontist or the parent manipulates this piece in the middle and it puts pressure on the bones to widen and separate that upper jaw. Your maxilla is your upper jaw. So I think these pictures are great. What you can see here is these are millimeter measurements. So they measured the widening of the palate. Before treatment, this patient had 40 millimeters of space, and after now it's 45 millimeters of space. You can imagine, I mean, 5 millimeters adding is a lot. So it widened, allows these teeth to come down into place and be straightened a little bit. And this alone is helpful for obstructive sleep apnea. And you can tell, this is kind of a small picture, but you can barely see, they took all these measurements of his airway, and you can see the widening after treatment just from manipulating your palate at the top. So an interesting way to go. I do think there are some orthodontists in town and in the Metroplex that are working on this, using these appliances. There are some other lesser proven methods along this dental orthodontic line, but I'm all for looking into this. And at least when you examine a patient, if they don't have enlarged tonsils, but they have a real narrow palate and a teeny tiny little mouth, it's a good question to ask. Are they at an age where we can try to stimulate some growth in this area and make it easier to breathe? This is kind of our old-fashioned stuff. Here's our CPAP, nasal CPAP mask. This is one brand, so they're doing a whole giraffe bit here, but nasal CPAP, nasal BiPAP, sometimes tolerated, obviously hard to get used to because it's hard to have something on your face and get used to it every single night. And certainly kids with some sensory troubles, that can be something that is an obstacle to treating their sleep apnea. We use sometimes plain old oxygen. This is actually a high flow nasal cannula system, meaning that it's not added oxygen, it's actually added pressure and flow. It's just not a sealed mask like a CPAP is. So this is air through these little cannulas, but in a more forceful way, called high flow nasal cannula. One of the newest methods to treat obstructive sleep apnea in adults is with what's called a hypoglossal nerve stimulator, and it is a surgical procedure. You may have seen the ads on TV for it, and it's a surgery where a wire is placed in the neck with a nerve stimulator then dissected around the specific nerve that's in your chin that innervates, that goes to all the muscles of the tongue and a couple muscles of your chin as well. Then there's a computerized piece that's put in the chest, and then one lead that leads down to the chest muscles to be able to sense when you are taking a breath and expanding your chest muscles. You turn this device on at night, and when you're having an apnea event, it sends an electrical impulse to tighten these muscles and thus make it easier to breathe. It pulls everything forward to then extend and make your airway bigger. This is called the Inspire device. And so this is the remote control that you wave over your chest to turn the machine on, and you can change pressures as directed by your doctor for this kind of thing. So it's specifically titrated to what each patient needs. It is FDA approved in adults that have obstructive sleep apnea, but recently, sort of recently, years now, patients with Down syndrome who are older than 13 who have had trouble with use of CPAP have been approved to use this. So we at Cook Children's have recently done the training necessary for this, and we've implanted our first patient with his device. And so we're in the process of having him use it and slowly titrating up right now in his voltage needs. So that's been an exciting thing for us to start up and have in the arsenal in terms of things that we can choose to treat obstructive sleep apnea with. There are other breathing abnormalities that can occur that count as a sleep disorder. Probably the next most common is central sleep apnea. Central sleep apnea are the pauses that occur in sleep. So your body is not trying to take a breath. This little wiggle is just the electrical impulse. So this is a nice big breath, and then a pause in breathing. So nothing is moving, and then obviously nothing is coming in here. So believe it or not, a few of these are allowed in everybody overnight, and they happen and in each of us every single night. But there's a certain number. You're not supposed to do more than 5 per hour. And the same thing can happen. You wake yourself up after having a central apnea, or you can have a change in your oxygen number. And so either of those things disturbing your sleep is not good. So if your problem is a central sleep apnea, not of obstructive sleep apnea, there's not something in the way of you breathing, your brain is not sending the signal to take a breath, then that can be a problem too. And there are treatments for that. Primary snoring is what we call it when you snore, but you don't have obstructive sleep apnea. In adults, that's also called upper airway resistance syndrome. So some people use CPAP for that. Some people have nasal surgery for that. Those are the two I can think of. Some people will use Flonase and make that a little bit better, or one of the other nasal steroid medications to just get rid of your allergic swelling. I think that's breathing abnormality. So now we move to Biddy and Bo's coffee. There is not a Biddy and Bo's in Fort Worth. I think there's one down in Waco. So this is a coffee shop where they hire people with special needs, and I think was started by a family with some kids with Down syndrome. Like I think this is Biddy and Bo. So if you drink too much coffee, then you put yourself at risk for movement disorders during sleep. Periodic limb movement disorder is actually much more common in patients with Down syndrome, although it occurs in 5 to 8% of children and certainly can occur during pregnancy. Actually, it's a big problem during pregnancy, and it is the movement of your legs in a rhythmic pattern while you are asleep. And yes, this is related to restless leg syndrome. I'll talk about that in a little bit because technically that's a little bit different. They're a very similar disorder, but restless leg syndrome happens when you're awake. So this is specifically a sleep disorder, happens when you're asleep. You can be diagnosed with periodic limb movement disorder when you have more than 5 movements per hour. And so this sleep study here, you can see the eyes are again at the top. And then we have some EEG leads. And then you just have these big sort of muscle twinges because we put one of the leads, one of the stickers on the top of people's legs. So it's your tibialis muscle that we're measuring. And so they have these big outbursts. And what you see in somebody's leg typically is at the ankle joint, their little foot will move up. That's what it will look like. And it's usually described more in the restless leg syndrome literature. When people ask about what it feels like, kids will say, it feels like energy is building up in my leg and then it has to move. They feel like they have ants crawling all over their legs, and so they have to shake their legs or move their legs. Some kids will rub their legs real hard against the bed or the side of the bed. These can happen mostly during non-REM stages of sleep to disturb your sleep. just hearing about movements at night may not mean you have a movement abnormality. You should also then have some evidence that not everything is going super well for you during your sleep. So you're tired in the morning, you are falling asleep when you're at school, you're more emotional than you should be at times, something like that. And once you're diagnosed with this, typically by having a sleep study, then interestingly enough, it can get better with iron supplementation, particularly in people who are deficient in iron. So sometimes if we're willing to wait and use iron, that can be an easy way to fix this. Sometimes we have to just go ahead and use medications because it's hard to wait for iron to work if you're in the middle of a school year and you need things to turn around quickly. Those are treatments for periodic limb movement disorder. This was a study done in kids with Down syndrome and looking at sleep studies done over a 5-year period. I think it was 2014 to 2019. They pulled out all the sleep studies of kids with Downs and then looked at, they only had questionnaires for 50 of them, but they had 418 sleep studies. So they looked how many of the kids had symptoms of leg movements, a pretty high percentage of them. And then how many of them really had periodic limb movements? 33% of them. That's a huge number of kids. So a lot, we know that kids with Down syndrome move during sleep. That is one of the things that I know that I hear from nearly every family is that they're just rocking and rolling all around the bed in all different positions and ways. But it even goes beyond that to be a specific movement disorder in 33%. And even more so than sleep apnea in this study, where there were 26% and then 15% who ended up having sleep apnea, but 33% overall had periodic limb movement disorder. Very common. The other movement disorders that I think of, this restless sleep disorder is our newest sleep disorder that was accepted by the American Academy of Sleep Medicine in 2020. And it is large body movements. So your entire body moving from side to side or flip-flopping from the waist down, like not just periodic leg movement, but your whole body is shifting more than 5 times an hour. That is actually treated with iron as well. Restless sleep disorder is shown to be mostly seen in children who are iron deficient. So there's something about having iron deficiency that makes your body want to move more. Rhythmic body movement disorder is the name and sort of the large category under which then we have body rocking, head banging, side to side body movements. Body rocking can be anything from just rolling side to side, like sort of shoulder to shoulder. That can also be kids who get up on all fours and kind of rock back and forth, or kids that bang their heads on their pillows or walls or side of their crib, all that sort of thing. Those kinds of movements are considered normal in the sleepy time, when they're in bed, typically laying in bed, trying to fall asleep, so they're drowsy and sleepy, can be commonly seen in kids until around age 5. Beyond that, we think that it should go away. And so if you have a child who continues to have these movements at the start of the night or continuing into the night, then that would be something to talk to your pediatrician and maybe your sleep doctor about. It can be associated with insomnia because to me, it means that a kid has developed a behavior, a movement, to help them get into sleep. And it can start as something just as simple as a shimmy back and forth. But if you have trouble falling asleep, the movements can become bigger and bigger. And then the child doesn't realize that the actual movements are causing them not to fall asleep. So at some point, it kind of shifts from being something that's soothing and helpful into sleep to something that's disruptive to their sleep. So it's worth talking about. It's very hard to treat, I will add, as the doctor end of things, but certainly worth talking about. And then my restless leg syndrome, trick question, because although I don't, to me, it's not a sleep disorder because you're awake when you're having it. But there's a percentage of people with periodic limb movement disorder that have these symptoms while they're awake. And it does seem like they are it's the same process in your body. It's the lack of enough iron to allow your neurotransmitters to work effectively in your nervous system. So the large nerves and large muscles of your legs are what's affected. So there are medicines that can be used for this too, but we try to start with iron just because that's a nice, easy one. Okay, good. Yes, my last business, Blake's Snow Shack, which is based in Decatur, so just north of here. Um, and if you have too many snow cones, then you may have brain freeze. And so here we are with your brain. This is your brain. It might be on drugs, I suppose. I'm certainly a caffeine sort of person, controlled and typically in the morning, and then sometimes a small cup at lunchtime. This is your brain. All these areas that are pointed out here and in the colors with the specific neurotransmitter in the parentheses here, these are all the centers. And I'm sure this is not all of them. This is what we have identified so far in our understanding of the brain. These are all the centers that have to work together to make sleep onset occur. So if we think about this, really complex things like learning, like swallowing, like walking on uneven ground, falling asleep, require so many parts of your brain to work together that it makes a lot of sense to me that there are groups of kids that have trouble with this, groups of adults for that matter. If you cannot have your brain work in concert, all of these things together, then you will have trouble getting to sleep and or staying asleep. So it's not a big mystery to me that we have lots of kids with insomnia or trouble with their sleep overnight, because we're asking a lot of all of the parts of their brain to work together to do that. So what I call cerebral disturbances, I'm not sure that's a great name for this category, but it's brief wakings that are happening overnight that are not because you have sleep apnea or not because you have movements that are waking you up. And this is when, now you can have what appears to be restless sleep with all of the other sleep disorders that we've talked about. But sometimes when I look at a quote, normal sleep study, and everybody's breathing looks fine and there aren't extra movements overnight, parents can still say, but the sleep appears so restless and they are in such light sleep that I tiptoe by their room or one gust of wind outside and they're immediately awake and having a full conversation as if they've never even been to sleep at all. And that can be because of frequent brief wakings that your brain is causing. So if we're looking at this sleep study here, this top line, the hypnogram, is all the sleep stages. So W is when you're awake. R is REM, which is your dreaming sleep. And it's this red thick line here, you're dreaming. And then N1, N2, and N3. And the N stands for non-REM. And stages 1 and 2 are your light transitional stages of sleep, and N3 is your deepest stage of sleep. So the two important stages of sleep for humans are N3, which is considered your deep sleep, where you sleepwalk and you wet the bed and you sit up and say weird things and then lay back down. And your dreaming sleep, which is when your brain is filing away all the memories of the day, which is learning. So whether it's filing away the math facts that you were focusing on during the day, or filing away the afternoon you spent with your grandma and recognizing that she loves you and that she's taking care of you and she is a trusted family member. So it's emotional learning as well as cognitive or school-based learning. You can see this person has pretty disturbed sleep. Now, you might also say this poor person was sleeping at a sleep lab with 1,000 things attached to them, and absolutely that is true. For the most part, kids end up falling asleep and then they'll show me what their night is like, generally at home too. Now, some real anxious kids might have a night like this at the sleep lab, but in any case, what you're seeing is a lot of short wake ups here, short wake ups and then back to sleep, and then one long wake up and then back to sleep, and then awake asleep, awake asleep. Then over here, awake asleep, awake asleep, awake asleep, awake asleep, like just tons of these short disturbances. And then I look, I mean, here's a few obstructive hypopneas down here, but this doesn't end up being enough to count as sleep apnea. It doesn't get to that 2 per hour kind of number. Here's the limb movement box, barely at the bottom. This is not going to be enough to be 5 per hour. Oxygen values look pretty good. A couple of little DSATs here, but nothing that's very exciting, mostly above 90% for your oxygen numbers. So this is a person who ended up not having any sleep disorder, but certainly had disturbed sleep overnight. So the only explanation that I have is that your brain is sometimes doing this. So these kinds of brief wake ups are seen more in kids with ADHD types of symptoms. So that's kind of that overlap with Down syndrome. Kids that are hyperactive in the day, I think of this as being kind of hyperactive at night, or a brain that has difficulty with focus during the day will have trouble focusing on remaining asleep overnight. So it's the same kind of thing we see in the day is what we see at the nighttime. Those kids that move and fidget and shake their legs all day are the type that move and rock and roll during sleep too. Anxiety will cause trouble like this, as mentioned, more commonly seen in kids with developmental delays. And I only add that because I see a bunch of kids every year that are in their 2-year-old, somewhere around their age range, with speech delay. So maybe not a diagnosis yet of specific syndromes or specific problems, but just speech delay. And their sleep can be so troublesome that I have often wondered if it's that they are frustrated by the fact that they're not able to communicate like they think they should be able to. And is that enough to make your sleep bad? Um, how do we fix it? Well, you try to get to the bottom of what is causing the problem and then you work on that. So, for example, in kids with anxiety or PTSD that are having trouble sleeping, that's what we work on. And so sometimes that would mean talk therapy, medications to address anxiety, medications to help with ADHD, anything else we can think of to get to the root cause. So sleep fragmentation is sometimes a way to describe the findings that I was just showing you in that previous sleep study. Fragmentation can be caused by breathing disorders, but fragmentation without other sleep diagnoses was looked at here in toddlers with Down syndrome versus typically developing toddlers. So these are the typically developing toddlers. They had 25 brief wakings overnight. In this study, they split up kids with Down syndrome that were thought to be good sleepers, very general term, versus poor sleepers. And they said that people who were staying asleep for 80% of the night on their sleep study were considered good sleepers. And if you were asleep for less than 80% of the night on your sleep study, you were in this category of poor sleepers. And I think this is only important because of the grade of severity here. So if you are a typically developing toddler or a kid with Down syndrome who's considered to be a good sleeper, you have about the same number of brief wake-ups overnight, 25. If you are a poor sleeper, you are really a poor sleeper. 35 events. And this is even an index. So that suggests that it's per hour. You're having some sort of fragmentation in your sleep. So we already know that there are some kids within the Down syndrome community that are even worse sleepers than others. I mean, that's no different from your typically developing kids, where some kids are great sleepers and it comes very easily to them, and some people have more trouble. So this, I was impressed by the huge increase in number of breaks in your sleep overnight, simply based on looking at this general, are you a good sleeper? Are you a bad sleeper kind of discussion. This is a super busy slide, but I did like the fact that it compared kids with Down syndrome are in the blue line and age normal are in the gray. So total sleep time stays about the same. This is age until you reach about age 4. And then kids with Down syndrome tend to get less sleep than their age matched children with normal chromosomes. The other sort of dramatic things that we saw are that in kids with Down syndrome, they have more wake after sleep onset. So falling asleep might be just fine, but you're awake at times overnight. Tends to get worse when you start to hit your teenage years. There we are. More arousals in kids with Down syndrome overnight than age matched here. Sleep efficiency is the percentage of time that you're asleep overnight. Kids with Down syndrome have a big decrease in the percentage of time that they're asleep. Really no change in sleep latency here, which is interesting. So falling asleep, everybody tends to kind of go back and forth and have some troubles. A little bit longer, it looks to me like in the teenage years here. Stage, not too much difference here in stage 1. Stage 2 sleep, kids with Down syndrome have more, and that is actually a negative thing because they have less stage 3, which you remember is that deep sleep that's so important for your body. That's when you refresh your body overnight, is stage 3 sleep, and they have less REM sleep. So some negative things there. So these are the recommendations that the American Academy of Pediatrics put out. I think this was updated in 2022. Specific recommendations for care in kids with Down syndrome. And we're trying to get earlier and earlier and more regular in terms of asking about sleep and what we're doing with regard to sleep to monitor everybody's progress. So as early as at 6 months of age, we should talk about what parents are hearing at night, what they see from their kid at night, what their schedule of sleeping is, anything that kind of gives us a tip off to how things are going. At 1 year of age, we start looking for your iron stores. And some of that was started years ago when we worried about lead paint and lead influencing how much iron was in your body. And now it's more because this is a great way to look at healthy movements during the day. And as we've learned through this talk, some healthy movements at night. You shouldn't have too many movements at night. And that is greatly influenced by your iron stores, which sleep doctors measure in terms of ferritin. Ferritin is one of the proteins that carries iron in your body. And so this is an easy measure. If it is a high normal number, we know that there's plenty of iron and your body is making ferritin so that the ferritin has a job to do. If you don't have enough iron, your ferritin numbers go down because there isn't anything for the ferritin to do, so it's not needed, so your body doesn't make it. And trying to measure your iron stores based on red blood cells, and so looking at an anemia or looking at a CBC to see how many red blood cells there are, doesn't help us. Your body preserves your red blood cells until you are absolutely almost out of iron. So you will have a normal red blood cell amount, even if your iron stores are quite low. So it's much better to measure by this ferritin number to know how we're doing. And then the recommendation is that every kid with Down syndrome by age 3 to 4 should have a sleep study. And that is simply because we know that we're not great about judging the presence or absence of sleep apnea by asking about what you hear at night or what you see at night. So that the decision was made, everybody should have a sleep study by this 3 to 4 age range. I think over 20 years ago now, maybe 15 years. So that's where we've gone with those recommendations. And there's my resources that I used. So now I'm sure, are there questions in the chat here? Let me look and see if I can see them.
Yeah, there are a couple.
Okay, good. Yes.
Can you see them or you want me to read them?
Maybe read them to me. I don't know what I did here with my screen.
The first one says, we were told iron could be the cause of our child's kicking, but now iron is coming up as helping to address the issue. What is true?
Yes. So iron is typically not the cause of problems. Now, that if you have severe kidney disease and you're on dialysis, if you have some of the rare congenital anemias and your iron is kind of all over the place, I do notice that super high iron numbers can also influence your sleep negatively. But I think in the context of young kid with Down syndrome, you probably still need iron. I think now iron can cause constipation, so I wonder, certainly stooling patterns can disturb your sleep. That can make that sort of difficult overnight. But I think I would say probably iron is helpful for sleep more than it hurts.
Okay. The second question is, we are using melatonin to help put our 11-year-old to sleep. I'm hearing the use of this is bad. Is it? And what would an alternative be?
Yes. And melatonin is such a hot topic these days. And I think that for a couple of reasons. I think the negatives on melatonin are that um, yes, some of this is my soapbox that I'll be stepping up onto. If you look nowadays in the grocery stores, so not even a specialized market of some kind, if you go to your regular old grocery store, the melatonin choices are quite vast. And they vary from combination products that have all kinds of things in them, in addition to melatonin, to just melatonin in these huge doses, 10 milligram, 15 milligram tablets that I would not recommend. Your body makes zero point 0.3 milligrams and sometimes even less of melatonin nightly. So we're not needing these huge doses of melatonin that are made for us now. So some of the negative press has been just because the pills are too chock full. The other problem is the companies that are making them that are not certified through USP, which is that specialized pharmacy, I guess, program. You have to send in your medicine and they certify that the milligram that you print on your bottle is actually what's in the pills. Companies that are not using that service are listing on the label the milligrams of melatonin that will be present on the date of expiration. So if you buy a 5 milligram melatonin tablet, you are probably getting many more milligrams because unless you're reaching that expiration date, they're accounting for that in their listing there. So there's a bunch of weird things surrounding melatonin. I tell people try to look for USP, try to look for a brand that you recognize or feel good about. The studies that were done in melatonin with kids with Down syndrome, originally autism, and then kids with Down syndrome, were done with a brand Natrol, Natrol, which is sort of a almost pharmaceutical grade, not quite, but almost a pharmaceutical grade melatonin. So you can feel good about using that brand and such. So I think first I would say, yes, in an 11-year-old, between 1 and 3 milligrams of melatonin is very helpful for falling asleep. We know that prepubertal children seem to have more of the sleepiness feeling of melatonin. And certainly above the age of 13, they may feel that too. Melatonin works on your circadian rhythm pathway, so helps your brain know that this is your nighttime. So melatonin works a little bit better if you have a regular bedtime, a regular wake time, and you're giving the melatonin at the same time every night. The one thing I worry about, and I worry about it with the medicines that I prescribe too, is that I think the way you talk about it is also important, making sure that your child understands that we're using this to help you fall asleep, but your job is to lie in bed, which should be in a quiet, dark, somewhat cool room. You do your best to not move your body and to stay in a comfortable position and think positive, calming thoughts. I don't want kids to learn that they just take their melatonin and that's how you fall asleep at night. I don't like falling asleep to be tied to something that's extrinsic like that. I like kids to think that they have a part in this too. And that's if you're choosing to use melatonin, we can have that be part of what that process is so that it's not just melatonin and then you're really hosed when you go on vacation and forget it kind of thing.
Great information. Thank you. We have a couple more questions. The first one is if wait a minute. Do we have to request an ortho or can we be referred for palate expansion consultation?
So this is where I'm trying, I proclaimed it at we had our pediatric sleep meeting this last weekend, and I proclaimed that I was going to try to do a better job of standardizing this process because currently what I tell patients is you need to talk to your dentist about your mouth appearance. I try to tell families what I see. I see that your child has very narrow nose holes, which we know in Down syndrome, ear canals and nares are quite narrow and small, and I see that your palate is very narrow, your teeth are crowded, and I feel like if this was widened, you would have an easier time breathing overnight and you have a diagnosis of mild to moderate obstructive sleep apnea. So I try to tell them all the sort of keywords to give to your dentist. And then typically the dentist will know who to refer you to. If you have older kids that have already been through the orthodontic world, which I feel like starts around 11 if you just are a kid who needs braces. But these are kids, the kids that I think about using retainers or expanders in are maybe around 6. I think we can go much earlier with some of this treatment and start work on it. So if you know of an orthodontist that you're comfortable having a consultation with and telling them these things, or if you talk to your dentist and then see if that person knows of somebody that is well versed in how to attack these kinds of problems. That's how we've done it in the past. I'm going to try to work on standardizing it because I do think there are some orthodontists who are a little bit more in tune with this early orthodontic work, and there are some specific devices that are now made that I hope will be shown to be helpful and used more in the future.
All right. The next question is, if my child goes on medication for a sleep disorder, what are the side effects?
Well, and that would be pretty specific to what the medicine is. But I'll tell you in general, when we are using a medicine to try to help sleep be better, then what we want to judge is it making your sleep better? And the best way to judge that is actually by your daytime. Now, if you have a kid who's coming to you to tell you that they can't sleep 5 times overnight, if we get that down to 2 times overnight, then that's great. And that would be a way to judge the nighttime. But usually I'm asking, can your kid get up in the morning and not seem sleepy? Can they make it through their entire day without laying their head on their desk? Are they falling asleep in the car as you drive home? You're 3 minutes from your elementary school, that kind of thing. So maybe just judging how the day is going. And certainly the kids then that don't have sleepiness, the kids that tend to get hyperactive or emotional when they're sleepy, you talk about those kinds of symptoms, that 1:30 p.m., 2 o'clock wild time where they're running around the classroom and in trouble all the time, or that 1:30 time where they cry every day and can barely get the afternoon started at school, those sorts of things. So you try to judge it by the day, whether it's making things better.
The next question, I have an adult daughter who has done the orthodontic expander. We watch iron levels. She has hypothyroidism and is often very tired and always falls asleep in the car. I don't hear her have many apnea episodes at night. She doesn't move often while sleeping, and I wonder if there would be any benefit to having a sleep study.
I think so. I mean, I think if you're sleepy enough that you are a grown up and you're falling asleep in the day, it can be really hard in some of the younger children. As evidenced by that chart, there's a huge range of how much sleep, say a 6 to 9 year old needs, although I would say they all need 10. But I think when you get to be an adult, you should be able to make it through your whole day and not be falling asleep. So, I mean, I think a sleep study would be helpful. I do. In exactly
Oh,
that kind of case where you've addressed, no obvious malocclusions and you're not hearing a ton of things overnight. A sleep study can sometimes surprise you. We wouldn't know if she had periodic limb movement disorder.
okay. My nephew is 7 and has Down syndrome. 2 to 3 times per night, he gets up and walks through to his dad's room, sleepily awake, not sleepwalking, and then walks back to bed and goes back to sleep. Is this a typical pattern or something to be concerned about?
I think what I would ask is, what is he getting? What's the benefit to him to do that? Is he, and are we sure that it's not sleepwalking? If he really is just walking in and then turning around and going back, I would wonder if it's sleepwalking because you're not gaining anything from doing that. If it's checking, like sort of a security, I don't love to use the word anxiety there because I don't quite think it's anxiety, but like worrying. Is everybody where they're supposed to be? I need to check on that. I would try to find out if that's what it is. It's not no, I wouldn't say that's a regular pattern. It's worth asking about or trying to figure out what's the cause of it or what's the reason for it and can we get in there, can we intervene somewhere to make it not happen. I think 3 is a lot overnight.
That seems like a lot.
Yeah.
Our pediatrician described clonidine, zero point 0.1 milligram, to help with going to sleep, and she's 12. She also takes Jornay. I'm going to really butcher all
Yeah,
these
Jordan.
medications
Yeah.
at night for ADHD. How do you feel about the clonidine?
I love clonidine. Um, so clonidine is a very old-fashioned ADHD medicine. Before stimulants were developed or able to be used in kids, we used clonidine in the daytime, and the bummer was that it made kids sleepy. So you tried to sort of balance the smallest amount that you could do because it helps you focus. It helps your brain focus on what you're trying to do. So now we fast forward. There are much better medicines for trouble with focus and distractibility and impulsivity during the day. Jornay is one of them. That's one of the stimulant medicines. Um, but we know that kids with hyperactivity move a lot at night. They have trouble falling asleep and trouble staying asleep. And that is, it's the hyperactivity, sort of the controversy of does your kid with Down syndrome also need a diagnosis of ADHD? Because I don't know, some of us argue about that. But the constant need to move and the difficulty with focusing, which allows you to fall asleep, is certainly present. And so clonidine is a medicine that you take a small dose of it, you lay down in bed, and it helps your brain focus. You remember the picture of all those centers in your brain that have to unite to get you to sleep. If they're all doing their own thing, then you will not fall asleep. So with clonidine, it helps the brain focus and work together to do that. I love clonidine because it's not really a sedative. If you needed to go in the middle of the night and wake the kid up and get out of the house quickly, you could absolutely do that. Um, it's not something that typically makes you sleepy in the morning. I've had a few kids, but generally you can sleep really well overnight with that medicine and wake right up and be ready to go do your school thing in the morning. So no, I love clonidine. I think it's a great medicine. It decreases some of the movements that we see overnight in kids. Doesn't make them go away, but it decreases some of them. So no, that's a common one for me. I love it.
Okay, she went on to add to that question that she wakes up at 2 a.m. every morning, or not every morning. She says wakes up at 2 a.m. to go out in the backyard and swing. She sits up and bends at the waist to sleep several times a night, and their whole family is exhausted.
Oh dear. Well, it may be time for you to ask your pediatrician to see a sleep physician because she still has clonidine in her system at 2 in the morning. So some of this might take some work to how do we troubleshoot her feeling like her only recourse is to go do her swinging. And she might be going to do that because that's her soothing, like this calms me, this keeps me chill. She might know that, ideally not everybody's swinging in the middle of the night, but yeah, that's a hard one. And it may be that she needs different timing of clonidine. So there's, different dosing or there are extended release formulations of that. So it might take a little bit more work than what your pediatrician is versed in. I love the clonidine, but I think maybe you guys need a little zhuzh, sounds like.
Okay. Two more questions and then we will wrap it up since we're going a few minutes over. Then next one is my son is taking clonidine, 2 tablets, 0.1 milligram. He still wakes up at night He comes into my room and then we go back into his room to sleep.
Did she say how old?
She did not say how old he
Yeah,
is.
and is on clonidine, you said, right?
Yes.
Yeah. So, it depends on the age, I think. And we would have to make sure that I think what then you have to get at is why do you feel like you still need to do that? Are you getting enough sleep? Is this a sleepwalking problem? Maybe we need to actually extend the sleep to get rid of the sleepwalking problem. Sometimes we have to put a little bit of a barrier in between the child and the parent. And sometimes that's as simple as we do an art project where we make a stop sign. So much of this then depends on your developmental abilities and what we need to do to try to get you to stay in your bed the whole night. Because with clonidine, that person could probably get back to sleep. So it's a matter of knowing that you could get back to sleep and feeling confident that you could get back to sleep, not being scared, not feeling like you'd rather be with your mom, that sort of thing. So that could take some work.
She added that he is 19 years old.
Oh, he's 19. So yeah, then we would need to put up some barriers and make sure that he understands this is where you sleep, this is where you stay. Sometimes we use an okay to wake clock, which is a clock that has a certain color when you are sleeping, and then it changes color when you're allowed to get up. So we help kids by pointing to it and teaching that this is how you know it's time to be sleeping. And then when it changes, it's okay to get up. That might take some behavioral work, and trying to figure out what is it that he's trying to get at when he comes to you.
Okay. And the last question is what can we do about anxiety attachment issues that contribute to trying to avoid bedtime and nighttime waking?
Yes, honestly, that typically is something that you have to work on in the day. So you have to be the kind of kid who can walk out of the room without anybody else and go down the hall and do something down at the end of the hallway and then be by yourself for a minute or two. Because you can imagine there's no way you're going to fall asleep, which typically happens in 15 to 20 minutes if you can't be by yourself for 1 minute outside of the sight of your parent or somebody else. And certainly there are a number of kids that don't ever leave the room. They find ways to stay and they're very tricky about it and they're funny. So yeah, I mean, we practice, we go around the corner and I'm going to keep talking so you can hear me, but you're not allowed to look at me. You start as easy as that and you work on the ability to be alone. I think that's when we ask kids to go be in their room for 10 hours in the dark by themselves, we're asking a lot and not everybody can do that. So I think working on that during the day, and there are some psychological methods to doing that. Some people call it practice academy is one of the example ways of doing that. But practice academy after school, you walk into the hallway and I'm going to stay in the living room or I'm going to be in the kitchen and you're going to go over there and I'm going to be right here. And I'm going to say 10 seconds, 20 seconds, or, so you work on there being longer and longer periods of time that you can be by yourself. So there are other little tricks to that too, but that's a hard one.
All right. Well, we don't have any other questions in the chat. I know I've learned quite a bit today, so we really and truly appreciate your time.
Of course.
Uh, Let everybody know that we will be able to share the slides. This will be recorded and uploaded to our YouTube channel, and we will email everybody so you can have everyone can have access to the information. And of course, Dr. Pearson's contact information.
Oh, good. Yes. And I'm at Cook. There are fabulous sleep doctors at Children's of Dallas, of course. So we're all happy to help. We love seeing our kids with Down syndrome for sure.
All right. Thank you. Everybody have a
Thank
great
you.
day.
Bye.